And so we are going to have a presentation today, and it will last through the hour. So we approximate about 90 minutes here. As all of you know, over the last year, the Department of Human Services and Iowa Medicaid Enterprise, IME, have been working on a process of transitioning Medicaid into managed care. The approach cannot move forward without federal approval from the Centers for Medicare and Medicaid Services, CMS, because CMS financially contributes to the plan. So in FY16, the percentage of the federal medical assistance contribution percentage was 54.91, and in FY17 it will be 56.74%. The transition to managed care was to occur on January 1st of this year, but CMS and IME's plan did not meet the criteria. CMS said that IME's plan did not meet the criteria they set for the transition to take place. A new date was selected for the readiness analysis, March 1st. IME must show CMS that it is ready for this transition. So before you, there is a document that CMS issued showing readiness actions needed for March 1st, 2016 to implement the plan. Today is an opportunity to find out if readiness has advanced since CMS's visit to Iowa in early December. So in an effort to keep our work transparent and accessible to all, we will be live streaming this committee meeting today. So there is a camera that will be live streaming to people at home who cannot make it here and don't have access to be able to make it here. So today we have two people who are going to be testifying to our committee, and I ask that we be orderly. We have the Medicaid Director and the Director of the Department of Human Services giving us an update on Medicaid managed care. I'd like to introduce Mikki Stier, the Medicaid Director for the Department of Human Services, and Charles Palmer, the Director of DHS. Could you please come to the table? I've asked Mikki to give a 15 to 20-minute presentation, and then we will open it up for questions after that. So, Mikki, the floor is all yours.
Good afternoon, and first of all, I want to thank you all for inviting us to come today and provide you with an update where we are with the CMS 16 initiatives in order to ensure readiness for our March 1 date. CMS has reviewed and approved the plans that we have put in place to address these 16 items for March 1st for that implementation date. And the majority of the 16 items are process items that we are working on fully implementing, and we're sharing with CMS our process and progress towards those implementations. There is one thing that I do want to update the committee on right now, and that is, I'm sure that you have heard, there was a ruling last week regarding WellCare, and a question has come before our department. We have been working on the reassignment of those members. Those members will receive a notification of reassignment first part of February, and we are outreaching to them in our member services and assuring that members understand choice. So that is an update as of Friday for you. I know that question may have come up, so I figured I'd address it right now for you. One of the initiatives that CMS has on what we call the 16 is our call center and the IME call center. For us, there are things that we monitor on our call center. We manage wait time, the overall call volume, and the average amount of time it takes for us to work with a member on that call. We do know that when we do mailings, and we are doing quite a few of those right now, that our call centers will spike. In fact, last week we managed 15,000 calls. An average wait time for that was you waited to get one of our member service representatives was 3 minutes, and it took us approximately 7 minutes to work with our members in addressing those calls. We monitored this on a daily basis. In addition to monitoring it, we also are monitoring the MCOs And we're also doing secret shopping on our call center as well as on the MCO's call centers. Key to those questions are, how they address a member, how they assist a member in selective of choice, and how that we can help those members navigate through the entire transition for managed care. We also are managing the provider call center, and very similarly, we're secret shopping the provider call centers as well, as we know it's critical that providers understand what they need to do and if they have concerns or questions. So that is one of the big areas on CMS that we are monitoring. In addition to that, CMS recommended and has reviewed our 30, 60, and 90-day communication plan. The goal of this communication plan is to work to eliminate the confusion and to provide information to members that can help us reduce the communication and confusion with the transition to managed care. In addition, we have outreach to the MAC Executive Committee and other key associations with our communication strategies, working with them to help us get communications out to both members and providers. We are right now in the middle of 11 training sites throughout the state for provider and member services. The MCOs are accompanying us with those provider and training events that we have across the state. We're averaging about 2,500 providers that have participated, and then we also have members there. We are webinaring all of those provider training meetings because we know that how to bill claims, how to process claims. A lot of provider questions will come up during the provider trainings that we're doing in these 11 sites, and we want to ensure that there is access to that training material, even if you're not able to get to one of those. In addition, we are prepared, and we have heard from one of our providers that they can't get into one of the provider trainings. We are prepared to do additional provider trainings. We also are specializing our provider trainings because we know that not all providers are alike. For part of that day, we'll break out to behavioral health providers in those trainings and also long-term services and supports for those trainings. In addition to that communication plan, there has been a series of informational letters out to our providers, and we've also been developing scripts that align in all of our call centers to make sure that information is clear. And we are soon to be launching some social media platforms for Iowa Health Link, which has not been launched before, but we will be launching those shortly as well. So communication is another big component of the 16 items that we are addressing with CMS. Network adequacy is a very large one, and I'm pleased that the last time we met, the MCOs have made significant network adequacy strides, and there is a handout that each of you have received, and I will walk you through this, and I'm fairly confident that in March 1st we will be able to demonstrate adequate networks. We are collectively and continually every day reviewing various reports and information that are coming in from our MCO partners regarding the status of their networks. In addition, with our MCOs, we are working with them on these reports to identify areas throughout the state and throughout various products and services that we believe they need to really stretch and look towards contracting, and assisting them with whatever efforts we can to give them the information about the providers they need to contract with. To date, the Iowa providers have signed more than 85,866 contracts with the MCOs. Each plan has enrolled over 75% of our currently active fee-for-service provider network, and more than 45% of the current providers have signed with all three of the MCOs. In addition to that, in-state providers, 75% of the fee-for-service providers have signed up with at least one MCO. Only 80%, or 23,000 in-state providers, submitted claims to IME in the past 12 months. And of the state fee-for-service providers who submitted those claims, 82%, or 19,655, have signed with the MCOs. Question was raised regarding out-of-state providers because we know bordering states are very important to us and access to bordering states are also critical. 56%, or 12,568, of the out-of-state providers have signed up with at least one MCO. Only 53%, or 11,000, of our out-of-state providers had submitted claims in the past 12 months. And out of the fee-for-service providers who'd submitted the claims in the last 12 months, we signed 7,612 of them with at least one MCO. We do know for our out-of-state providers, a lot of times it's a one-time incident. It's a single case event that we have a lot of out-of-state providers that we do sign with them. In addition to proving or working through network adequacy with our providers, I would remind the committee that there is also, for the first 30 days, the safe harbor provision that providers will be paid 100% reimbursement. There's the continuity of care definition and time period that is still in place with Medicaid managed care transitions. And in addition to that, there's an any willing provider clause that if an any willing provider wants to contract with an MCO, that provider will receive a contract with an MCO. So those are all key components in terms of network adequacy and what we're moving towards ensuring that we meet the CMS's standard with network adequacy. Another key area in the letter that you have is the long-term services case management. The goal is to ensure that no one falls through the crack in this transition. We've reached out to the 80 statewide agencies that are currently offering case management. For the 20,000 members that are currently enrolled, and inquired about those 20,000 members to those 80,000 agencies. Are you planning on continuing your case management after March 1st? Are you not going to continue your case management? Once we have this information, we have been providing that to the MCOs so that they can outreach directly to a contact person in those agencies for those individuals that are going to, those agencies that are going to continue with case management. We want to ensure that there are contracts with the appropriate MCOs. And for those agencies that have decided not to continue case management, we're outreaching with the MCOs to ensure that we smoothly transition the members. A question was raised, will case management be conflict-free? And the answer is yes. Any decisions on level of care for our members rest with the department having to sign off the approval of those level of cares. And we have a standardized assessment that evaluates the level of care for the members. The Long-Term Care Ombudsman's Office, we looked forward to coordinating with the Ombudsman's Office to ensure the members receive their care and support. In fact, we have begun training with that office. We have done a Managed Care 101, and we have, as last week, walked them through the HCBS waivers, what the waivers are and how those waivers work to support our members in long-term services and supports. And last week received about 40 referrals from that office to our member services line. And we will continue to have follow-up meetings with them to enhance our relationship with that office. In terms of Hawkeye has been a transition, and we know it has been a transition. One of the things that we have been working on with United Healthcare and Hawkeye is the definition of medically necessary. There has been a question regarding the continuation of speech therapy. United will honor all prior authorizations for the kids that have had speech therapy. In addition, if our providers can prove medical necessity, Hawkeye will take care of those children and continue that speech therapy. And we've outreached to the provider that had a concern regarding that and are having ongoing conversations with one of those providers. I have outlined for you the key areas in terms of the CMS 16 and how the department is moving forward with those 16 items. In addition, there was one item on here which was the pharmacy issue. The pharmacy issue was related to one of the MCOs, and they weren't able to accept claims. That issue has been resolved, and CMS has approved and signed off on the pharmacy issue. And the last issue on the 16, or item on the 16, is the contract. The contract amendment for the MCOs is with CMS and has been revised, and they have that, and they are reviewing it at this time. So this is my update.
Thank you, thank you. Well, we have a couple questions for you. It seems as though, we have a lot of constituents that they still have grave concerns about this, and we get a lot of emails, and we've related that to you and let you know that. The level of complaints have they decreased regarding the call center wait times?
Absolutely, they have. I mean, because we have added we are up to about 100 staff now on those, and we are not hearing complaints. It's more, how do I connect to my provider? How do I ensure that my application is in? When will I get my member card? When will the MCO outreach to me? Those are the kind of calls we're getting now in our member services.
Okay. The complaints about adequacy and accuracy of information provided by both IME member services and MCO call centers. So this morning there were a couple of my constituents that called and then they sent me emails. So a question like, is my provider in the MCO network? This was in Cedar Rapids. The member services said, you have to call your physician about it. I can try. Your doctor could be in here, but I'm not 100% sure. I prefer you go to the actual doctor. And this doctor is not in the MCO network yet. AmeriGroup said, keep in mind, because we are in the process of enrolling, it may be in progress and not in the system yet. They may not have finished their credentialing yet. You can always ask them which MCO they are deciding to go with. So you can see that there's a difference between member services and what the MCO is saying. Here's another one. The difference is, does the MCO have specialists close to my community? So this was a neurologist that they were asking about. The member services said they're covered through AmeriHealth and United Healthcare, but AmeriGroup said the neurologist can get an out-of-network authorization or a single case agreement, or you have to find a neurologist in the network, search by zip code. As of now, I do not see any neurologists in the network in your area. And then in the very final part of the conversation, they asked about implementation delay, and the quote was, it is a potential reason. I'm sure I'm in the state of Virginia Beach. We handle 12 states. We are the main call center. So that was for AmeriGroup. So our people are calling Virginia Beach and vying for time with 12 other states, which I'm not happy with because that's not what the MCOs told us when they were courting the state of Iowa back in the spring. Does the plan have value-added services that would benefit me? Again, there were two different answers for that, and I can share these with you, Mikki. Okay. Does the MCO have call centers or helplines available beyond regular business hours? Member Services says, I don't know their hours, but I have their numbers. And then AmeriGroup says, I don't know the Iowa market hours yet. Right now it's 8 a.m. to 8 p.m. No, wait, it's 7 a.m. to 7 p.m. EST. So there's just a, even though they might have scripting, it sounds like the people on the other end of the line aren't giving the kind of, and this is just, these are random questions. So I would ask that, we just need to get some consistent information. And it sounds like the provider network is not what it appears to be over here is how many contracts have been signed. We've been talking to a lot of providers, and some of them are still pretty hesitant about signing. They may be close to signing, and they may have given a verbal agreement, but they have not signed contracts yet. That's at least what we've been seeing. The mailings. Are the mailings going to the wrong place or not at all? How can you find that out? How do you know?
So when we do a mailing, like we did the initial enrollment packet mailing, we did use a service through the mailing or company that actually, there's a database with the United States Post Office, so they could actually ping those addresses and get those corrected before they go out. We do have a lot of our population that is transient and moves quite a bit. When they come in from one mailing, we have put a process in place that we will then verify with either our eligibility services. If that piece of mail comes back, if we can send a more current address, we will. So we've used two filters now. One is the post office to see if the addresses are current before it goes out in the mail, even if we have it with an address. And the second then is if it does come in and is returned, we use member services and eligibility services to try and figure out what that address is and try to get those back to the right person. In addition to that is if a family member does call and say, we do know that, for example, when we did the initial mailing, that if the children were in programs and they were two very separate programs, they received different mailings because they had different case numbers. We have now been able to cross that But if a member says, I haven't received a packet, we immediately turn and mail those packets out to those individuals based on the feedback we get from member services.
And then we're getting a lot of, not hearing anything back from the MCO, even though the selection was made in December. So I've gotten probably 5 or 6 emails from people who were assigned the auto assignment. They took the auto assignment, and then about mid-January, they called just to make sure they were on the list. They weren't. And so they started to wonder because they hadn't heard. So when they called, they were not on anybody's list anywhere. And so I'd like to find out just how many people and how you find that out, if the MCOs can let us know if they've had contact with those people that they initially auto-assigned.
We could follow up with them.
Yeah. The Managed Care Ombudsman Program is receiving hundreds of calls from members who say the hold time is too long at IME or they can't get the information they need. So we heard that testimony during the appropriations meeting. Letters to members did not include information on TTY.
All of the new mailings going out do have information on the TTY lines. We do have those resources in place, and historically, and in full disclosure, at times the mailings did have the TTY lines on it, and at other times they didn't. So going forward, the consistent policy is that all the mailings for the department will have that information on them.
All right. And then how are you communicating to Hawkeye members?
We are doing an individual mailing to the Hawkeye members, and I believe that is happening within the same weekly period as the other enrollment letters that are going out to them. We did an initial outreach to those individuals when we did have to move the well-marked individuals onto United. Then we are also aligning their call centers with scripting and information that we have as well. And we have started sending to the Hawkeye board the letters and stuff that we will be sending out to families, so the board is fully aware of what we are sending out to them.
And then how are you communicating about well care no longer existing for us, for the state of Iowa?
We have a draft letter of communication that says basically you are being reassigned to one of the 3 MCOs, and they are AmeriHealth, AmeriGroup, and United. You need to select a new plan for us, and we're just redirecting them as a reassignment letter.
Are you giving them any grace period, any longer period to figure out if they're providers in the new network, or?
They will have up to February 17th. However, then they can continue to make a choice clear into 90 days after that period, and then they can change for good cause. And good cause means that their provider isn't in the network that they had chosen.
All right. And then what happens when a member changes from one MCO to another? What happens there?
In terms of their information or the member?
Yeah.
That the Iowa, because we are the ones that do the enrolling and the eligibility for those members, we would then move that, we would get notified that the member has made a choice, and then IME would notify the MCO of the change.
And there's enough time there for them to adapt and react to that?
And yes, we're putting enough people on our call centers and our provider centers to be able to do that.
Okay. And one last thing, I think I asked this of you at the oversight meeting back in December, is that some of the providers have boards. The nonprofit providers have boards, and you've requested, or CMS apparently has requested the Social Security numbers. And is it true that they will be asking for fingerprints next year of those board members? Okay,
so what you're talking about is a federal requirement called ownership and disclosure. It is a federal requirement. One of the things that we have started to work on with the MCOs is administrative, I just lost the word, but okay, it is administrative efficiencies. So in a meeting this morning, one of the things that we talked about is that Iowa Medicaid would manage the ownership and disclosure through Iowa Medicaid, so that information now is being collected by us, and we would work on a process in which to notify the plans of the ownership and disclosure requirements that are required by the federal government, rather than having 5 of us asking, or various people that they need that information. So that is a requirement. The fingerprints that you are referring to is, again, that once providers do re-enroll with Medicaid, it is a federal requirement that we will need to start collecting fingerprints.
So our hospital boards, all of our boards of all the providers who are here, the nonprofits, they will have to give up their fingerprints.
I'm not sure it's the board, and I will clarify that for
Okay.
myself, but I
Okay.
do think it is the providers.
The providers, all right, okay. With that, I'm passing along to Senator Johnson, had some questions?
Thank you, Madam Chair. Thanks for being here. The average wait time on the calls is 3 minutes. What's the range? I mean, I'm just asking from personal experience. I've been in that category before, and an automated message, and waited 59 minutes and almost took a battery down in my cell phone. So, I mean, what's the range? I
Our
mean, I'm
range-
hearing that, I'm continuing to hear that it's can be a long time. I mean, it can be a long time. I guess that's what I'm getting at.
Right now, with us adding the additional staff, again, our average wait time is about 2.4 minutes, 3 minutes, and it can go up as high as 7 minutes right now in the last, and this is for about 2 weeks. This is what we've tracked.
Well, that would be good. You said that you had completed the number 15 item on this update on the actions that are needed for readiness, the pharmacy item. Are there others that are completed too?
We have received feedback that they're in process, and like I said, these are process items. For example, our communication plan has been approved, and now we're implementing it. What the feedback we have received from CMS is that they want us to monitor that plan and modify it. For example, some of the feedback we heard today in terms of our call centers based upon feedback we receive from members or providers. So that's what we are doing, is we are continually making progress and great strides in those areas and modifying them accordingly.
Is it possible to know how each of those 16 what state of readiness they're in before March 1st? I mean, so that the committee would know where this stands?
We can, again, in our daily and our weekly calls with CMS, we can provide them with that feedback.
So I don't know if you can quantify it, but Director Palmer, were you going to say something or no? Oh.
Well, what I would add, we would love to know. And so we're asking the same question and then asking if there are any of those areas that they feel that we are not making adequate progress. As Mikki has said, the plans are approved. They're regularly monitoring those on weekly information, and we have not heard anything that caused us to believe that we were not making satisfactory progress. We too, for all the reasons you would want to know, would like to have an early warning if things were not going correctly.
Couple more things, Madam Chair. Mikki, you said that you were fairly confident that we would begin on March 1st. That's not a strong description of what I heard before January 1st. How confident are we? And I don't know what you mean by fairly confident.
Well, I'm very confident. I mean, if you look at the statistics that we gave you on our network adequacy, and I'm fumbling through pages, but I mean, we have 75% of our current fee-for-service providers that have signed up with our MCOs. And then we're fast approaching on 45% that have signed with more than one of our MCOs. It's a broad network of providers that have signed up. Our communication plans are strong, and we are modifying those daily based upon feedback that we receive. And then in addition to that, you know, the outreach that we are doing to long-term services and supports is very critical to ensure that the case management is transitioned without anyone falling through the cracks, and actually outreaching with the plans to those 80 agencies is a key initiative. So that is where my confidence lies, is the outreach and the expansiveness of the network that we've actually been able to build since January.
Let's say that implementation begins March 1st. Then what happens after that? What is CMS's involvement in reviewing how managed care is proceeding in the state of Iowa. I mean, do you understand my question?
You're
I mean,
asking me, is CMS going to continue to monitor
Well, I mean-
this after
I mean,
the implementation of
Yeah.
March 1st?
I mean, are there benchmarks that then have to, or I mean, is it going to be a 3-month review, a 6-month review? Is there any, I just don't know if there's anything that exists like that.
To my knowledge, they have, that has not existed in any other state, and nor have we had those conversations with CMS.
Thank you. Madam Chair, it's 35 days until implementation, or the planned implementation. So are we going to have another update soon? I mean, that's not a lot of time. And I think that this is a very good meeting to have, and I think we need another one and another one. So I don't know.
I agree.
Okay.
I agree.
All right. Thank you very
Absolutely.
much. Thank
I
you.
agree.
Thank you. Thank you, Mikki. Thank you, Madam Chair.
We have in the queue Senators Reagan, Yocum, Shelgren, and Sigabart. Senator Reagan.
Thank you, Mikki. Madam Chair, WellCare, so we're resorting these folks. You said you sent out a letter and they have, these are the options. Are you assigning them at that point?
We are reassigning the individuals that we tentatively assigned to one of the 3 plans. We'll divide it approximately 141,111 individuals that will be tentatively reassigned to one of the 3 MCOs.
Okay. So what about market share and the, I mean, balancing it all out so one group doesn't have all the more costly individuals? When does that happen?
Because the way we did the tentative assignments initially with all 4 of the MCOs, it's a random assignment. So it's an equal distribution of randomness that assigns those members.
Okay. Well, last week we had a training in the North Iowa area, and what I have heard from those trainings, and having been at one of the training where there were 800 people in the room, I'm not seeing that as an effective way. It's getting better, but we're 35 days out, as Senator Johnson pointed out. And at that, my understanding was many were given the answer, here's my card and I'll get back to you on that. And we're talking billing, and for some of these agencies, that's really a critical part of providing the services. And also with that, we have a lot of large providers that are very concerned about the rates. Small providers as well, but large providers that are going to have a huge economic impact on the state of Iowa. Can you address a little bit about going back to the 2013 cost report, or we would actually go to the rates for some of the providers on that as well? So those 2 questions.
So in terms of provider training, and one of the things that we also have within our provider services and our member services is the ability to send a team to a very specific either association. We did that with one of the associations that wanted specific training on behavioral health billing and how would that work. And we were able to arrange that with our MCOs and with us to go to that association and work with that group of providers. In addition, we have staff that will go to wherever in the state that, they arrange that this group of individuals want some more hands-on providers. We were able to do that with some of the outreach staff that we have actually put on place for the implementation. So in addition, we're also offering webinars if there's additional webinar training. And we're actually, the MCOs themselves are offering webinars and additional training as well. I do know that those providers that are smaller and need additional support are waiver providers, and we're trying to outreach to them as much as we can. In terms of the rates were set in July of last year. One of the rates, and we've talked about this a little bit, that we are still working with is the HCBS waiver rates. And we know that we have a next generation, if you will, in terms of working with those providers to look at those rates. If providers in any of those areas and any of our providers are concerned with their rates, we have had provider rate setting look at them and reevaluate them. Some of those agencies we have made adjustments to based on additional data and information.
And one final question is, can you imagine being an individual that gets assigned to one of these companies, and have to make a choice between their, what do you advise them in those kind of situations?
And are you giving me the example that the hospital may be signing with one?
With one group, and their doctor actually is not assigned with anybody.
Over time, I would hope that the physician or the provider would sign with the plans. If I, and they can continue to see that provider as an out-of-network provider, or for the first 30 days, they'll be able to see that provider for 100% of that cost.
I'm just saying there are many, many confusing things out there for individuals, and we're not talking a small group of people. This is, I seriously get daily calls or emails regarding this. And I think that all of you will hear from all of the folks in this room that that's how it's going. I cannot imagine that March 1st that we are ready to move forward on this.
Well, and as the plans sign those larger providers and those larger systems that do have a larger swath of providers, I think a lot of that they will start to align, because as we're seeing with larger systems, those providers have signed with multiple MCO contracts.
Well, you said, for example, on the out-of-state, it was 56% with one provider. I mean, we're talking a lot of border communities that are probably, there's more issues there. Anyway, I don't want to take up all the time for everybody else. Thank you.
Senator Yoakum.
Thank you, Madam Chair. So I want to go back to Senator Reagan's comments earlier. So your handout says that in terms of in-state providers, 75% sign up with at least one MCO. How many providers in our in-state providers have signed with all three?
45%.
45% of the in-state providers have signed a contract with all three of them?
Yes.
Okay, so it goes back to, because I'm one of those parents in this boat where none of her medical providers in Dubuque have signed a contract. Unity Point has, but none of her waiver service providers have signed. So what are we telling families to do about a situation like that?
We're working.
Who do they have to
select families can continue to see those providers, and those providers as out-of-network. We will continue to outreach to especially the waiver providers. We know that those are supportive services that are very much needed. We are outreaching to the case management agencies to try to help families understand what we need to do for outreach to those families.
So let me go back to your point that they can go out of network, but they're going to get a 10% ding. And a lot of these waiver service providers are already running on a shoestring. And a 10% ding or reduction in the reimbursement rate is going to be pretty darn difficult for them to keep the doors open financially if that goes on for any length of time. So we may see fewer providers actually accepting Medicaid. Do you see that?
I see that possibility, but again, with the outreach that we're doing between the MCOs and the state, we're hoping that we can help educate those providers and secure those contracts.
I want to talk a little bit about case management. I know I've talked to the director and I believe you as well, that the lessons learned from CanCare and other states was, number one, you need to have a very robust ombudsman's program. And I believe the standard is 1 to 3,500, one ombudsman to 3,500 Medicaid recipients. The second thing they pushed very vehemently was that we need to have a very robust, independent, conflict-free, whatever word you want to use, case management system. So how many case managers are actually been hired by the managed care companies right now?
I don't have that total number. I can find out for you.
Okay. Oh, okay.
Sorry about that. And then, how many, are you aware of how many case managers have actually closed or downsized since all this started?
We know of 2 areas in the state that the case management has closed at this point.
And which 2 are those, please?
I believe it was Woodbury and...
So Sioux City area?
Those are 2 counties. Woodbury County has discontinued case management, and I believe Warren.
Okay.
But there could be others. Those are 2 counties.
Okay. And then how many brand new case managers are working for the managed care companies right now?
I would have to get you those numbers. I don't have those.
So I understand that the word's gone out that we can keep our current case or people can keep their current case manager until August, is that correct?
That's correct.
Without reduction in reimbursement or anything of that nature?
That's correct.
Has that been have people been widely notified of that August 1 date?
I believe so, yes, in our mailings.
Okay, because I honestly have not gotten any mailings as a parent since Sarah's original assignment. The only other mailing I have received is to tell me that there was an error in the instruction booklet regarding Ruth Cooperrider's office, that she was not an ombudsman that was to be contacted, that there's a difference between long-term care ombudsman and the office of the ombudsman. That's the only
There
thing
should have
I've
been,
gotten.
I believe in that, there should have been a flyer that tells you about the dates moving and the choice changes. It was part
I'll
of
check
that.
again, but
Yeah.
I brought it with me, so I
Okay.
have it. The only thing I remember is a notice that that was an error in the instruction booklet that we got back in early December, whenever that went out.
Okay.
You also stated previously that we needed some code changes that would be necessary to implement managed care. We haven't seen anything yet.
We did some rule changing,
I'm talking about code changes, actual changes in the law that are necessary in order to make managed care work. Let me just run through some of the code sections that I think we need to be looking at. 514I, which is Hawkeye, because I believe the current statute is pretty clear that the board itself has to sign off on some of this. So that'd be 514I. 249M, which is the Hospital Healthcare Assessment Program. 249A, 249K, 249L, 249N, which is the Health and Wellness Plan. 225C.20 on county case management. 331.389, which is the mental health region, and then 331.393. Those are all different code sections that some of us have identified there where a statutory change will be needed in order to fully implement managed care in the state. Would you get back to us on that? Okay. And then finally, I'm wondering how we're implementing that whole idea of a safe harbor when the new managed care rules that were filed emergency last December said that as of January 1, there was a 10% penalty for out-of-network providers was going to apply. So how are you implementing that safe harbor when the rules are saying January 1, 10% reduction, but we're saying, no, now you got till April 1. So how is all that working? Because it's in conflict with the emergency rules. So will you need to amend those rules, or how are we doing this? Because I believe those rules come back up before the committee in February, this next meeting? They should. And that those rules still say
January
10% reduction in out-of-network as of January 1. So they're definitely in conflict with what our practice is, I believe, right now. So like some clarification on that as well. Okay, I will stop there, but I'm sure I'll have a few more questions. Thank you, Madam Chair.
Okay, so we have Senator Shelgren, Sigabart, Bolcom, Johnson, and Peterson. So Senator Shelgren.
Thank you, Madam Chair. Actually, I appreciate that my colleagues have answered a lot of the, or asked a lot of the questions that I had, but I do have a couple more questions. Just in the handout that was handed out, it said fee-for-service network of 29,961, and then we have AmeriGroup, AmeriHealth, and United. And whenever I see a number that's over 100%, it surprises me. And so, why does United have 5,000 or almost about 5,000 more providers than the fee-for-service? I mean,
They have commercial providers.
and so that's what's bumped their numbers up to that level?
Yes, it would.
Is there a certain minimum threshold that is expected for each of these providers? In other words, if AmeriGroup only has 76%, but United has 116%, did the department actually set some threshold to say, as a provider, we expect you to have this much participation? I mean, is there any threshold that's a hard number for that?
The department has not set a threshold, a hard number for that, no.
Okay. My question with regards to case management was already asked at that point. And I'm going to go ahead and pass. Thank you very much.
Senator Siegebart, do you want to go, or do you want to recover there from your conferencing? Go ahead.
Agree with Senator Shelgren on his point up here, the 116, and you said it was commercial providers. But I would take it back, and if you go to the front end of that line, it says 29,961 in the network. Well, each one of those can have 3 different providers, right? So if you do the math 3 times that, it gives you the number that it says the total contract possible is 89,883. So I'm wondering if it's just they have more than one contractor, one of the 3 MCOs.
We do know, yeah, we do know for United, part of it is their commercial plan.
Do you have any idea how big a group that would be?
We can find out for you.
Okay. Then what should we as legislatures say, recommend when we get asked, and we've been all getting phone calls, which one of these MCOs should I pick? And they're trying to determine which one's the right one, and we're struggling with that. I wish I had a script to follow when they would call on that.
I would ask them to call member services. Our member services has conflict-free training to actually help them understand very basic information about the 3 MCOs, and then also we have a listing of value-added services that are also on our website, as well as our member services know what those value-added services are.
Do you have the actual phone number? Could you? They did. Oh, they should. Okay, yeah, they should send it to every legislator, actually.
Should send what?
The phone number for that member's services that they need to contact.
Yep. It's an 800 number.
Okay.
800-338-8366.
Excuse me. I'll shut up. Go ahead.
800-338-8366. Or if you're in Des Moines, it's 256-4606.
Well, if you do that, it will be just like he said, that adds 150 people to your call hotline.
Right.
And believe me, they've been getting phone calls. I'm sure everyone has.
Right.
So if we can help you out in this regard, we'll all be very happy. Thank you, Madam. Thank Director Stier for being here today.
Yep.
Thank you, Madam Chair.
Right, thank you, Senator. Senator Boltham.
Thank you, Madam Chair. I have a couple questions that deal with your handout. First, I appreciate that United has private contracts, but it doesn't really relate to the 560,000 Iowans we're trying to sign up. I'm not sure that data needs to really be included here. It says that we have 29,900 providers, and then we say only 80% have submitted, or 80%, nearly 24,000 have submitted claims in the last 12 months, and then the total possible contracts, I think, is the 29,000 times 3 is the total possible contracts. And then it says we have nearly the same amount as total possible contracts is total reported care management contracts. And it says, so it would appear that 95% of contracts have been signed, and you say only 45% of
Signed with
all three. Well, this data would suggest that nearly everybody has signed contracts with all 3. So I'm slightly confused, but I appreciate that that nearly 50% have signed. It seems to me if I live in Iowa City or Dubuque or Mason City, and I have somebody that needs services, that I really want to get every MCO and every provider to make a deal. I want all my providers to sign up with all the MCOs, much like the current Medicaid program is, where most of the providers, or all of the providers, have signed up with IME. And in order to have the choice that most consumers are going to want, we really do want all the providers to sign up with each of the companies. And we're only to 45% of that world at this point, which I think is grossly inadequate, frankly, as a network. I mean, I'm glad that we're that far along, but this is supposed to go live on March 1st. It's pretty clear the network adequacy, in my judgment, is a little light. In terms of the reassignment of the WellCare folks, when will the letters go out to those 125,000. I think you said sometime in early February.
The 1st of February.
1st of February?
First week of February.
First week of February. So people will have maybe 14 days or a little bit more to decide if they're.
And then they
gonna-
will have 90 days
another
after
90.
that.
Okay. So do you think that's enough time for people to make a judgment about it?
Yes.
Okay. How many, what percentage of enrollees have switched to another MCO from the MCO they were auto-enrolled to? Are you tracking that, where a member actually goes through this maze of phone calls and calls all their providers, because that's probably the quickest way to figure out whether your provider's in a given MCO? Do you know if?
We can get you that data.
Do you think is there a lot of that going on where people are saying, or are people basically getting auto-enrolled and they're just,
We're not seeing a lot of that right now. We're seeing some of that, but we will get you those numbers.
okay. Like I'm interested in like what percent of the world has changed in that regard.
Okay.
Okay. Maybe the final question. I'm interested in the case management issue, and I didn't see it in the memo, but I've heard somewhere that case managers or care coordinators had to be signed for people, I think is it waivers and in the long-term care system, that they would have to have case managers assigned on the front, that we'd have to verify that from day one they had a case manager. And it's about maybe 60,000 people is my recollection.
There's 20,000 individuals through 80 case management organizations in the state that currently have case managers.
Okay.
We have outreached between, the Department of Human Services has contacted all of those 80 agencies and inquired, are you continuing with the case management of the individual members you have today going forward into March 1? If yes, then we have those members in that agency assigned to an MCO. We alert the MCO that that agency is continuing and give them a contact information for that specific agency to get a hold of them and set that contract in motion. If that case management entity says, no, we are not continuing, we also then alert the MCOs that they need to put in place a transition for that case management if that agency isn't going to continue prior to the March 1 date.
Do you think with the WellCare the re-enrollment of the WellCare folks, that you're going to be able to accomplish that in a couple weeks' time?
We've been working on it for a couple weeks.
Okay. So final question. So there's a couple issues around medically necessary services, which I won't get to now, but do you have documentation at this point showing that each MCO, what their prior authorization requirements are going to be?
Well, they have, and what we have shared, and I believe they're on the MCO's website, are the provider manuals. The provider manuals will have the listing of what their prior auth requirements are.
So it's going to be clear to providers how that's going to work?
Yes.
Very good.
And
Madam
it's
Chair.
part of, it's part of the provider training as well. And if it isn't clear, we'll make it clear.
Okay. Madam Chair, thank you. I think it's pretty clear we're not ready to move ahead on March 1st. I think this obviously needs more time. And it's really, I guess I'll stop with that, Madam Chair, because I was going to say something that I probably shouldn't say.
Senator Holcomb, I can come back to you at the end after you've gathered your thoughts, perhaps. How about that? We have Senator Johnson, you're up again. You've passed, okay. Senator Peterson.
Thank you, and thank you to the committee for allowing me to sit in. I serve on the Hawkeye board, so was interested in coming. My question deals with our kids who have been part of the Hawkeye program. As you know, if you were a child that was part of the Hawkeye program, your provider didn't necessarily have to be a Medicaid provider to give you services under Hawkeye. Talk to us about the number of providers under Hawkeye, what percentage have signed on to be a part of each of the 3 MCOs.
I will get you that data.
Do you have it immediately accessible, though? I mean, like, when would I get it?
I will get it to you this week.
Okay. We read about the report on the number of ombudsmen needing to be 1 per 3,500. We've all received letters from kids who receive Hawkeye services, that services that they received under Hawkeye are now not being covered. So my first question about that is, do we have someone specifically lined up to be an ombudsman for our children? I believe the Hawkeye population, is it roughly, what's the percentage of kids that are in the Hawkeye percent?
I believe it's like 30, 40%. Yeah.
Okay. Do we have a child ombudsman?
Not that I'm aware of. We do have a separate call center. We have a separate member center and a separate provider center and separate outreach for the Hawkeye program.
Okay. I would like to alert the committee that I think children have different medical needs than grown-ups. And, you know, when we see the letter coming that a child has to have suffered a stroke before they can have speech services is completely terrible. And we need to make sure our kids have advocates working for them. There was another article that talked about the savings program, and one of the things I noted was it said one of the ways they were going to save money was to hold maternity care service payments for 2 months. Could you explain that to me? What does that mean?
And I might call the CFO up if I don't have this accurate, and that's Jean Slaybaugh, but those are called kick payments. Jean, do you want to come speak to that, please?
The savings from the maternity case.
Can you please identify yourself and then?
Oh, I'm sorry, Jean Slaybaugh, CFO with DHS. The savings that was identified related to maternity case payments is really just a delay in maternity case payments. It's a natural delay when you transition to managed care and are paying a case payment for maternity. So when the MCO receives a claim that indicates that there was a delivery, the MCO will then bill IME for that maternity case payment, and those case payments will be made at that time. So it really isn't a true savings long-term. It's a delay in those payments that has an impact in state fiscal year 16.
Okay, I think you just made my point. A shifting is not a savings.
That's correct.
If you have to pay the bill, you have to pay the bill.
Correct.
So if you're shifting payment, what we're really doing is we're hurting providers around the state when we are calling it savings, yet it's really delaying a payment. Am I correct in saying that?
Providers will submit their claims to the MCOs. The MCOs have to meet our provider claims payment standards. It's the payment to the MCO that is delayed.
Okay, and what, do we have rules as far as how quickly providers are going to be paid under the new system?
I don't know if we have rules, but we have contractual requirements.
Yeah, maybe go over those with us, because I know a lot of us have providers that are really worried that the paycheck is going to be delayed in getting to them, and a lot of them don't necessarily have the capabilities.
For clean claims, it's either 10 or 14 days. 14 days for clean claims, and there are performance incentives, if you would. We withhold 2% of the capitation payments for performance incentives for the MCOs. One of those performance requirements is timely payment of claims.
Okay, so the fastest a provider could count on being paid for clean would be 14 business days, so 3 weeks?
That is the longest period. They're supposed to pay claims within 14 days.
Within 14 days if it's
Correct.
clean. And then what if it's not considered clean?
I don't remember that off the top of my head, but it's in the RFP and we can certainly get it for you.
Okay, I think committee members are going to need to know that too. Thank you. How many of the providers that provided care for our kids were not Medicaid providers?
I'll give you that data.
Okay, so you'll get us the number that weren't, and of those, which ones opted in and which ones did not. Okay, so I just want to make sure we all understand this. So a family who has Hawkeye, they would have gotten a letter saying you're going to switch to an MCO, and then they had the opportunity to switch, and then CMS came and said, we're not ready to go. So then Hawkeye got another letter saying, if you are with Wellmark, we're going to switch you to
WellCare.
No, they were Wellmark.
Wellmark, excuse me.
Yeah, they
my
were
apologies.
Wellmark.
Right.
So Wellmark didn't get to keep going because the state made the decision to cut them off with a hard date, even though we didn't know. So the parents got a letter, now you're on United, and now they're going to get another letter if they had gotten assigned to WellCare, that they may be shifting again. So some of these families may have had 4 shifts within the past few weeks, correct?
I don't think it's 4 shifts. They would have been able to select a plan, so they would have shifted. And then in the transition period, because we had to do a transition period, they would have moved to United. So that's 2. But if they were with WellCare, that would have been a 3rd.
My apologies, Senator Peterson. I just have some follow-ups here. You know, you've heard testimony from our experts today, but you've also heard, the experts have heard conversation from us or questions from us about our concern about the providers. Certainly we are concerned about the consumers, and that's who we hear from the most. But the providers, some of them say that they're going to go out of business. I mean, we got an email from a woman who runs an agency, and she said she may close her doors at the end of January. And they provide a service to their community, and they're running out of money. So are you concerned that not only some smaller agencies or providers or clinics could go out of business, or even that doctors are going to say, we're not going through this anymore. We're not going to take any more Medicaid patients anymore. This is just too much. We can't afford the 4 pieces of software. We can't afford somebody said they just spent $40,000 on software technology to change over to all this, $40,000 they didn't have. Aren't you concerned that people are going to not be able to do the work that they've done for years and years for the people of the state of Iowa?
Let me answer that. I'm concerned, and we are looking at case by case some of the individual situations where someone does not feel that their rates at the floor is adequate. They are still in a negotiation with their MCOs. So in many cases, I'm assuming if they signed on with their MCOs, that they arrived at a rate level that seemed to be sufficient. We also have providers that on a regular basis choose not to be in the Medicaid program, and we have people who have not been in the Medicaid program choosing to come into the Medicaid program. So there are multiple reasons that people choose to either be in the program, not be in the program, limit how many Medicaid patients they take, and vary that from time to time. Overall, my concern is that we have an adequate delivery system available across the state and that is accessible and quality for the Medicaid patient or consumer. That's the overriding. It's important to me that the rates that are paid are reasonable and fair, and that's why in certain situations we look at those individually. We would continue to be available to do that, and am open to discussions where individuals or associations have felt that our overall rates are not reasonable or unfair or are working negatively against a given provider. Because between the time the floor was set and today, there could be some other things that have gone on, which we've taken into account in our criteria, like have those individuals taken someone from one of the, a more difficult individual from one of the state facilities, and that their costs are actually higher, or that they have done something with someone whose funding stream should have been higher, open to looking at, and that we're doing that. Again, on the aggregate, I do know that we will have people coming in and out for a variety of reasons.
When Senator Peterson was asking about the clean claims, now I have heard that in the provider manuals, the MCOs are saying not 10 to 14 or 15 day turnaround, that they actually have 60 days, 60 to 90 days. And maybe I'm wrong, but could we check into that? That was actually a clean claim, not a contested claim, because then if it's contested, the appeal goes on and it goes farther out than 90 days. So can we check on that?
Yes.
I think a lot of the providers here will say that IME was quick pay and you guys were, you know, a clean claim got through quickly. What they're nervous about is going, you know, signing on. They're going to have this longer length of time. We've had several providers take out lines of credit that they've never had to do before in an effort to anticipate the transition from one payment group to the next, and they're petrified that they're going to lose their shirts on this. We've even had people say that they put their own personal money, you know, in their agencies or their clinics to try to make sure that they're going to float. So that's a concern, especially when the state is asking providers to do this. These are wards of the state. These are people who need our help. I have a question about Delta Dental. Is Delta Dental in or out? Are they going to function independently, or are you going to pull them into managed care?
Delta Dental is a managed care program, but it's independent from this managed care initiative.
So there are no efforts to ask Delta Dental to be part of this whole thing later. Are they going to still manage care independently, or the way that they've been going? We've heard that they might be part of this whole push across.
Well, I think first of all, we're very interested in, well, let me say, first of all, I think Delta Dental has done an outstanding job of the delivery of service. I think most people will feel that Delta Dental's service delivery has exceeded what we previously had. And so we thank Delta Dental for that adjustment in their delivery. We probably have greater dental access for Medicaid patients under the program. That was one of the reasons that we didn't want to disrupt what was a successful delivery system in development. At the same time, when we take a look at a holistic approach to care, certainly your dental situation is part of your total situation. So the question of would Delta Dental, would that set of services be best incorporated into with the other 3 MCOs in terms of the coordination of service? That's a fair question. What can we do in the interim that would address that separation and see if there is a way to bring that about closer? That too is an option. And going forward, we certainly want that integration so that we're looking at the total patient, the total individual, their dental needs as well as their total physical conditions. And the future would be based on what we assess in that process. And what is the negatives of having them outside of being part of an MCO.
So is the answer yes?
The answer is that is a open agenda item as we go forward.
All right, okay. Senator Bolcom.
Thank you. Well, on the Delta Dental, it sounds good in theory, right? I mean, holistic management, but it's pretty clear we've bitten off more than we can chew right now, and I think it makes some of us nervous to think we're not managing what we've taken on at this point. To add the Delta Dental piece to it at this point would seem to be a little premature. Chuck, what do you, in terms of looking at, I'm interested in the provider advocacy, the network advocacy issue, and I think being only at 45% with 3 different providers in the network, what would be your percentage? It seems to me we need number needs to be more like 80%. And I think I remember at one of the meetings we had over the interim, this was talked about, and there was a number thrown out more like that number. So what's your take on this issue?
We have heard, going through this process, a 50% number, an 80% number, looking at 3 MCOs collectively, individually. What I would say is that as we look at actual geomaps, which we would be glad to share with you, that the picture across the state in terms of access and geographic access, if you were to take into account choice, meaning that at least you would have a choice between 2. You said 3 would be ideal, and the fact that we have 3, that we are clearly moving in that direction, and that right now we feel we're clearly in a pretty good place at the beginning. At the same time, going back to Senator Johnson's comment, because of the decision that was made January 1st, I'm not ready to rate my level of confidence. I would say it is it's certainly high, but we'll keep working, we'll keep closing whatever the gap is, we'll keep building on it. And to the comments about what happens after March 1st, I think it's critical that we continue to put together an oversight process that assures people that this continues to grow. I want to exceed fee-for-service. I want this to be a better, more accessible program than we have in fee-for-service.
Senator Reagan, did you have a final question? All right.
Yeah, Senator Yoakum.
Anyone else? Senator Yoakum?
Thank you, Madam Chair. So let me ask about subcontracting. We have heard from many people that all 3 managed care companies or organizations are subcontracting, for example, transit services. How much of that is going on? I mean, we're not just talking about our providers having to set up an IT system to deal with 3 managed care companies and different billings and codings and prior authorizations, but also all the companies now that they're subcontracting with as well. So do you have a handle on that? How much subcontracting is going on? What I've heard mostly was the transit services. What other services are being subcontracted by the managed care companies?
We do know that all the plans have a subcontractor for transportation services. Just like IME has today, we have a subcontractor for our transportation services.
So our providers are going to have at least, I don't know how many, I mean, the 3 managed care companies plus at least transit subcontracting and all that criteria.
We do know that of the subcontracting for transit, I believe 2 of the MCOs are using the same vendor that the state is for transportation services.
I heard there was some concern that perhaps we haven't been on transit services, that somehow maybe we weren't quite billing things correctly in the past. Is that true?
Not that I'm aware of.
I've heard that from actually some of the providers. So we need to check into that. I believe there was a standard 30 miles, 30 minutes for access. Is that true? Is that for waiver or medical or what?
30 miles, 30 minutes is for urban. 60 miles, 60 minutes is rural and specialty.
Wow. So University of Iowa Hospital is 100 miles from my home. If none of Sarah's medical docs in Dubuque sign up, then I got to start looking for docs, medical docs in surrounding communities?
If it's again, they can go out of network, and she can continue to be
At a 10%
seen.
reduction if they'll take it. Okay. So I want just one last thing, and that is that in some other states, the SIS assessments are now being used to drive the reimbursement rates. Have we talked about that at all in the state?
No, we haven't.
Okay. Thank you, Madam Chair.
Is there anyone else who would like to make another question? All right.
Rural areas are going to be in trouble.
Thank you, Mikki.
Thank you.
Thank you, Chuck, for coming in. I think we're going to take up Senator Johnson's recommendation and have you back a couple more times before March 1st. I think that's due diligence for this committee, and certainly there will be some good comments on oversight too, and we'll get your feedback on an oversight bill. So thank you for coming. We're
Let me
going to
just
hear
say
the
that
Ombudsman Alliance report
Senator-
on Wednesday, January 27th, and any bills that are ready. During caucus week, we'll most likely have only one meeting, and we'll run bills and have some time for Democrats to caucus that meeting, so Republicans might want to think about that too. Ranking member. Yes, Senator Johnson.
Thank you, Madam Chair. I would say, because we don't know yet what the final status will be.
I'm sorry.
No. Okay, there he goes. Okay, there he goes. Goodbye. That it is our responsibility, because we are a standing committee and also with the Health and Human Services Budget Subcommittee. I mean, since we haven't decided what permanent oversight might be legislatively, we've got to continue to have meetings on this. This is, I mean, that's what I think that's what you're saying. That's what we should all realize. We have that responsibility here. Yeah. Okay. Thank you.
And we will have an oversight bill that we're rolling out. And that's something that I think we all need to join in and find out if everybody agrees on things. Yes, go ahead, Senator Yoakum. Oh, Director, yes.
I just wanted to reinforce, I know this is a significant event in the lives of Iowans, and I know all of you are getting a number of calls. We are more than willing to sit down with you collectively or individually as we move ahead over the next couple of weeks. So if someone has something they want to sit down with us, they can contact our legislative liaison. And having regular meetings to keep you up to date, we are very much, would very much prefer to do that. The more communication, the better. And many of your questions and concerns at times triggers something for us where we can follow up on it as well. So in some ways, that's what I think how oversight could and should work, is that we identify the things between us that we try to address. So thank you for the opportunity to meet with you.
And thank you for reminding me of one thing. I want to say Paige Thorson and Amy McCoy have been very responsive to the questions we've had. They've turned answers around, not always ones that we want to hear, but they've turned things around very quickly for us. So for those of you who are at home and listening to the live stream, that is a positive thing. So with that, I'm going to ask that Senator Sigebart move that we adjourn. So thank you. Thank you all for coming today.